goodness. You look good.
Using sterile technique, cut the cord with a scalpel below the clamp that had been placed at birth and about 1 to 2 centimeters from the skin line. Make the cut perpendicular to the umbilical cord rather than at an angle. Insert the catheter into the umbilical vein. The course of the vein will be up toward the heart, so this is the direction you should point the catheter. Continue inserting the catheter 2 to 4 centimeters, less in preterm babies, until you get free flow of blood when you open the stopcock to the syringe and gently aspirate. While one person holds the catheter in place, another can administer the appropriate dose of epinephrine or volume expander, followed by 0.5 to 1 milliliter of normal saline to flush the drug through the catheter into the baby.
I still don't see color change.
Okay, the color is not going to change. This baby's been down for a while.
Okay.
We don't have good cardiac output. Good,
Ready?
good.
Okay, resume. Yep. 1 and 2 and 3 and breathe. 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 3 and breathe. 1 and 2 and 3 and breathe. And 2 and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2.
Jeanette, can you reassess the heart rate? It's been about 30 seconds of additional compressions.
About, I'd say 30.
Okay, I'm going to need to put a line in. Ritu, can you take over the
Yep, got it.
tube? Thanks.
1 and 2 and 3 and breathe. 1 and 2 and 3 and
Here's your
breathe.
gloves.
1 and 2 and 3 and breathe. I'm going to move to the head of the bed.
I'll hand you the pan.
1 and 2 and 3 and breathe. 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 2 and 3 and breathe. 1 and 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 2 and 3 and breathe. And 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe.
Sharp on the field. Okay, I've inserted about 3 centimeters. Let me see if I can get some blood return. Got blood return.
Intubation is a complex procedure comprised of many steps. These steps, performed correctly, will result in clear visualization of the airway and appropriate endotracheal tube placement.
The endotracheal tube is placed through the vocal cords under direct vision.
Poor visualization of the airway may be improved by elevation of the tongue with the laryngoscope. If the laryngoscope is inserted too far in the oropharynx, the view will consist of the esophagus and surrounding tissue. To improve the view, pull the laryngoscope back along the base of the tongue until the airway drops into view. If the laryngoscope is not inserted far enough into the oropharynx, the view will consist mostly of the tongue. To improve the view, slide the laryngoscope down the base of the tongue until the airway appears. If the laryngoscope is off to one side, the view will include a small portion of the airway and surrounding tissue. To improve the view, pull the laryngoscope out along the base of the tongue, center it, and push it forward again. When lifting the blade, raise the entire blade by pulling upward in the direction the handle is pointing. Do not elevate the tip of the blade using a rocking motion or pull the handle toward you. Rocking, rather than elevating the tip of the blade, will not produce the view of the glottis you desire and will put excessive pressure on the alveolar ridge. If the laryngoscope is inserted too far in the oropharynx, the view will consist of the esophagus and surrounding tissue. To improve the view, pull the laryngoscope back along the base of the tongue until the airway drops into view. If the larynx is difficult to visualize, external cricoid pressure may help bring it into view.
Place the baby's head in a sniffing position. Gently open the baby's mouth. Press the leading tip of the mask flat against the baby's hard palate with your index finger. Gently guide the device along the baby's hard palate toward the back of the throat, past the tongue into the hypopharynx until you feel resistance. Use your other hand to stabilize the LMA as you remove your finger. The tip should now reside in the esophagus. Use a syringe to instill 2 to 4 milliliters of air into the cuff. The LMA may move slightly outward when inflated. This is normal.
Okay, we're in. Section, pull out, and then we'll respiratory now.
CPAP is administered by placing the mask of a flow inflating bag tightly on the baby's face and adjusting the flow control valve to the desired amount of CPAP. Generally, 4 to 5 centimeters of water is an adequate amount of pressure. CPAP is administered by placing the mask of a T-piece resuscitator tightly on the baby's face and adjusting the PEEP valve to the desired amount of CPAP. Generally, 4 to 5 centimeters of water is an adequate amount of pressure.
I have your 1.5 mils of the 1 in 1,000 epinephrine for
continue
the
compression.
Thank
Thank you. Now we're not going to flush that in. We're just going to put it in directly
Let's
and
coordinate.
then bag it in.
1
Okay.
and 2 and 3. Breathe.
Okay. Actually, this is a good time
3.
to give the epinephrine.
Do you want to assess the heart rate before you give it?
We just had.
You just- okay.
And it was less than 60.
1 and 2 and 3.
That's one part.
Breathe. 1 and 2 and 3. Breathe. 1 and 2 and 3. Breathe. 2 and 3. Breathe. 1 and 2 and 3. Breathe. 2 and 3.
Karen, you want to take this over? That would be great.
3. Breathe. 1 and 2 and 3. Breathe. 1 and 2 and 3.
Oh,
Breathe.
If you all wouldn't mind
2 and
switching
3.
places,
Breathe.
or
1
if you
and
can
2
move to the head of the bed, Kim, then I can put this.
Do you want to take over
UVC in
compression?
place.
I will.
I am here to record. Okay, great. Thank you very much.
1 and 2 and 3, breathe.
We're
1
about
and 2
5
and
minutes
3 and
into
breathe. 1 and 2 and 3 and
compressions
breathe. 1 and 2
on a
and
baby
3 and
who
breathe.
was
1 and 2
bradycardic
and 3
prior to
and breathe.
delivery
1 and
from
2 and 3 and breathe. 1 and 2 and 3
abruption.
and breathe. 1 and 2 and 3 and breathe. Stats are in the 60s. Breathe.
Okay.
1 and 2 and 3 and breathe.
Do you want to
Heart rate
reassess
is
before I
40.
re-drape? Because I think,
Yes.
okay.
Breathe. I'll reassess. Breath sounds are clear.
Let's go ahead and go up on the oxygen again because our sats are still quite low.
Okay.
It's about 60.
Heart rate is 40.
Still 40. Okay, I'm going to go ahead and put this line in.
Can you turn up the oxygen too?
Yes.
Can you reach it? Okay. Great.
1 and 2 and 3, breathe. 1 and 2 and 3 and 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 breathe. 1 and 2
So Glenn,
and
as
3
soon
and
as you're
breathe.
able to get that epinephrine to us, did I ask you for a second dose of epi? 0.3 mLs of 1 in 10,000?
I got that drawn up right
Oh, great, thank you. And as soon as you've got that, if you wouldn't mind drawing up 30 mLs of fluid, of normal saline, that would be great.
1 and 2 and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe.
Heart rate's reading 50s.
Okay,
1 and 2 and 3 and breathe.
Sats in the 60s.
okay.
1 and 2 and 3 and breathe.
As soon as I get this line in, I'm gonna go ahead and give the epi again.
2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
Okay, I've got a knife on the table. Okay.
1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
Okay.
2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
Glenn, do you have that epi ready? Okay, I'm in at 3 mLs.
I do. Here's your 0.3 mLs, the 1 in
Thank
10,000
you
epi,
so
and a 1
much.
ml syringe, and I also
Okay.
have a 1 milliliter flush
Hold on,
for
let
you
me
as well.
assess before
Great.
you give the epi.
I will. I'm gonna be suturing while you're doing that.
Breath sounds are clear. Heart rate
I
is
think your
40.
flush, I can drop that 30 mils.
That'd be great.
I'm going to
Thank you,
continue
that's a flush.
compressions.
So less than 60 still?
1, 2, and 3, and breathe.
Okay.
Yes, 1 and 2. And
Okay,
3
I
and
have
breathe.
blood
1 and
return,
2
so I'm
and
gonna go
3
ahead and give the
1 and 2
epinephrine.
and 3 and breathe. I'm going to reassess before you give the epi.
Thank you.
So breath sounds are clear. Heart rate is 40.
Okay. I'm gonna go ahead and give the epinephrine.
Okay.
I gave 0.3 mLs of 1 in 10,000, followed by 1 ml
1 and 2 and 3 and breathe.
of normal saline chaser. Now I'm going to suture the line in, and then Glenn, once I get the line sutured in, would you be able to, do you have that normal saline ready?
Yeah, I do have it ready. Let me know
Great,
when you
thank
need
you.
it.
So 30 mLs of normal saline, 10 per kilo.
1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
Okay, so our
1 and 2
sats are
and 3 and breathe.
52,
1 and 2 and
and our
3
heart
breathe.
rate is
1 and 2
still
and 3 and breathe.
47, but I just gave the epi, but maybe we should go up on the oxygen
1
again
and 2 and 3 and breathe. I'll
when
go
you
up
get
on
a
the
chance.
oxygen.
Yeah.
1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3. It's been about a minute. You want me to reassess?
That would be great, thank you. I'm
So
ready
we're
for that saline whenever you are,
Here's your
Glenn.
30
Thank
milliliters
you.
of normal saline.
Okay, great. Thanks.
We're clear and even bilaterally. Our heart
Okay.
rate is 50.
All right, so we'll need to resume compressions.
1
Thank you.
and 2 and 3 and breathe. 1 and 2 and 3
And our
breathe.
SAT
1
is
and 2
still-
and 3 and breathe.
Are
1
we
and
already
2
at
and
100%?
3 and breathe. 1 and yes.
Okay.
And breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and
And I'm
breathe.
giving
1
this
and 2
very
and 3
slowly.
and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1
Heart
and 2
rate's still in
and
the
3 and breathe.
50s.
2 and 3 and breathe. 1 and 2 and 3
Stats are
and breathe.
58.
1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
You might want to
3 and
reassess
breathe. 1
at
and
this
2
next
and 3
juncture.
and breathe.
Oh, I see gasping respirations. Looks like the baby's making a respiratory effort.
I'm hearing respiratory effort.
Great. Well, unfortunately, we're still SAT of 63. Heart rate is coming
60.
up.
It's increasing.
Okay, I see it coming. What? Want to just? It's already above 80. Okay. We're close to. All right. So we can stop compressions. Our SAT's coming up as well.
All right, should we get a bed set up in the nursery and head over there?
And we also need to talk to the father or have him meet us over in the nursery as well. Glenn, would you mind calling the nursery and telling them that we have this patient that's coming over on a ventilator?
Yeah, hi, it's Glenn calling from the OR. We have a baby who's going to need a bed set up. There should be a ventilator at the bedside. Thanks.
Okay, so before we go over, ET tube is secure. It looks like there is color change in the CO2 detector now.
Great.
Perfusion's better.
I think his
so.
perfusion was just so poor before. We
We're
weren't seeing any
hearing,
color
can you listen
change.
for breath sounds one more time before we head over?
So we have a sat rate now of 89 and a heart rate of 116, 120.
Okay. Is infant
clear.
stable to move?
I think we're stable to go.
Moving her bilaterally.
Great.
Sounds good.
And I think, Glenn, if you wouldn't mind also just having the father meet us over, bringing the father over to the NSU, the nursery and meeting us there. Thank you.
Okay. Let's go.